All right, welcome back to another episode of Pathagonia, everybody. Today, I'm going to go over non-neoplastic thyroid. So it's a pretty short section, but good to review. For me, when I think of thyroid, the most thyroid that I get to see so far is when I'm in cyto-ICC or the cytology cases. Frequently, obviously, thyroid is gone after in FNAs, and also if I rotate on the OPS service, then I'll get to see some, but just a good review. So let's get started. Some normal findings for thyroid: you're going to have follicular epithelium, which is flat to columnar with round nuclei with finely granular chromatin, and that's going to be positive for PAX8, TTF1, thyroglobulin, CK7, and more. You're also going to have, normally in the thyroid, you're going to have colloid, which is bright pink, frequently with calcium oxalate crystals, which is seen best by polarization. Colloid is less common in parathyroid, so that could potentially be helpful during a frozen section analysis, because sometimes in that region you're trying to differentiate is this thyroid tissue, is this parathyroid, etc. In the thyroid, you can have frequent metaplasia. This is often seen with chronic thyroiditis, which makes sense, right? Like chronic irritation, the cells there are going to undergo metaplasia and transform into something that's more resilient. Kind of like survival of the fittest of the cell type is one way of thinking about it. You have oncocytic or Hürthle cells, which are larger cells with abundant eosinophilic granular cytoplasm and large nuclei with prominent nucleoli. You can also have squamous metaplasia. And another normal finding are C cells. C cells are often hard to see on H&E, and they're single cells or small clusters between follicles, typically, and they stain with calcitonin and neuroendocrine markers as they release calcitonin, which helps regulate calcium levels. All right, so some incidental findings in the thyroid. You can have solid cell nests, which is a solid nest of cells with ovoid nuclei, finely granular chromatin, and frequent grooves. No keratinization typically, and there are remnants of the ultimobranchial bodies, which I am not familiar with. But they stain with P63 and loss of TTF1 in these solid cell nests. You can also have ectopic thyroid, which can be seen in any location from the tongue to the suprasternal notch, usually in the midline. With inclusions and lymph nodes are somewhat controversial, and most instances likely represent metastases. You can also have thymus or parathyroid, and skeletal muscle. Skeletal muscle can particularly be found around the isthmus, and benign thyroid can intermingle with the skeletal muscle. You can also have endocrine atypia, which is random and usually focal nuclear pleomorphism, as we see here in this image. Pleomorphism referring to the shape of the cells, and you can see this is much larger than some of the adjacent cells. And endocrine atypia is thought to be a degenerative process and not indicative of malignancy. So next up, we've got black thyroid. So black thyroid, referring to maybe with a color that it would look grossly. Maybe the thyroid appears very dark or black with abundant black pigment. You can see that grossly and microscopically, and that's usually from minocycline or tetracycline administration, with no impact on thyroid function. So minocycline and tetracyclines are notorious for causing this aberrant pigmentation in various parts of the body, some of which can be the thyroid. All right, moving right along with our beach vibes going. So next up, we've got thyroiditis. And thyroiditis, the first category, is a classic chronic lymphocytic thyroiditis, which is also known as Hashimoto thyroiditis. This is the most common autoimmune thyroiditis, frequently causing hypothyroidism, more common in women, and the autoantibodies is what causes this, such as antithyroglobulin, among others, and this can be treated with hormone replacement. So what you're going to see microscopically is a diffuse infiltration by lymphocytes, often with germinal centers, and frequent Hürthl or oncocytic cell change. And there's also a fibrosing variant of chronic lymphocytic thyroiditis with dense fibrosis with keloid-like bands confined to the thyroid, unlike Rydell's, which we will get to. Moving on. Next up, we've got subacute granulomatous thyroiditis, also known as de Quervain disease. So in this entity, you're going to have self-limited inflammation. It's more common in women and presents with a prodrome. And that prodrome is a painful thyroid gland and can often occur after viral infection. So if you have a question or a case in real life, someone recently had a viral infection and now their thyroid is painful, you could potentially think of de Quervain's. Commonly, this is asymmetric with uneven inflammation. Early on, you're going to have acute inflammation or hyperthyroid, and later, you're going to have epithelioid histiocytes, multinucleated giant cells, chronic inflammation, and fibrosis. So I remember from board studying or just in general, painful in the thyroid, that's just kind of a buzzword that they like to test on for de Quervain's disease, or it can, more importantly, be helpful if it's painful. It could potentially be de Quervain's, like in practice, if you're trying to work a case up. All right, moving on, we've got Rydell thyroiditis. So Rydell thyroiditis is also known as invasive fibrous thyroiditis, which is a fibrosclerosing inflammation of the thyroid and adjacent soft tissues, usually IgG4 related, and you're going to have destruction or replacement of the gland by dense collagen with keloidal-like bands, with increased plasma cells and phlebitis. It's very rare, but you can have a hard wooden thyroid upon palpation. And here you see those dense bands of collagen that look keloid-like bands, like in a colloidal or a keloid scar. You would see these dense collagen bands. So if you see that in the thyroid, you can think of Rydell thyroiditis. Next up, palpation thyroiditis. So this is an entity that can be caused by manipulation or palpation of the thyroid. And microscopically, you're going to see scattered foci of giant cells, granulomas, and or foamy macrophages with other inflammatory cells near the ruptured follicles. It's presumed to be due to vigorous manipulation, and it's asymptomatic and incidental. And it kind of makes sense if you think about it, because you have giant cells, which are typically in pathology we associate with reparative change or some kind of healing process. And if you're palpating the thyroid vigorously, it's so close to the skin surface that you could be actually damaging some of the cells in the organ itself. So that would make sense that you may see some giant cells or other reactive changes. Moving on, we've got hyperplasia. So hyperplasia of the thyroid, commonly associated with Graves' disease. Graves' disease is classic, and that's going to be caused by thyroid stimulating antibodies, which stimulates thyroid hormone synthesis, leading to diffuse proliferation and hyperthyroidism. Graves is more common in women, and there's a diffuse follicular epithelium hyperplasia, as we see here, with non-branching papillary projections and scalloping of the colloid, which is this entity here referring to these scalloped-like areas that are cleared out around the colloid. And you often have tall pink cells with frequent lymphocytic infiltration. Next entity, we have dyshormonogenetic goiter. That is a tongue twister. So this is going to be caused by a genetic defect in thyroid hormone production, leading to elevated TSH via feedback loop, which causes gland hyperplasia, but no increase in production, and it's autosomal recessive genetically. So all thyroid tissue is abnormal, with scant to absent colloid in this entity, hypercellular nodules, fibrosis, and prominent cytologic atypia. So on IHC, it's going to be negative for thyroglobulin, positive for PAX8 and TTF1. And medically, this is treated with hormone replacement and surgery for symptomatic goiter. So dyshormonogenetic goiter, it's a complicated word, and if you look at it cytologically, it's complicated as well. It's very messy, a lot of pleomorphism, atypia, so you can kind of relate the complexity of trying to pronounce that with the complexity of the cytology. Endemic goiter. This refers to thyroid hyperplasia in certain geographic areas. Usually it's secondary to dietary iodine deficiency. Iodine is needed from a nutritional standpoint to make thyroid hormone. Pathologically, it resembles adenomatous hyperplasia due to other causes. So what does adenomatous hyperplasia look like? Well, that's our next entity. So adenomatous hyperplasia is a multinodular thyroid gland enlargement due to follicular epithelial hyperplasia. Very common, like a lot of these entities in the thyroid category, it's more common in females. It's mostly unencapsulated nodules with pushing borders, and most nodules contain abundant colloid. There are variably sized nodules, some may be dominant, with epithelial metaplasia and hyperplasia being common, and you can see cystic change, hemorrhage, calcifications. Goiter is generally a clinical term, not a surgical pathology diagnosis, and a total thyroidectomy is often needed for symptomatic disease. So some other lesions you can have in the thyroid are post-FNA changes. So after an FNA, you might have hemorrhage and hemosiderin-laden macrophages or granulation tissue, which makes sense. Maybe there's some loose blood in the area or some healing going on, which would make you think of granulation tissue. You can also have metaplasia, such as squamous metaplasia. You can have infarction or fibrosis, and nuclear atypia after an FNA. You can think you're disrupting that area anatomically with a needle, doing an aspirate, so it's going to mess with some of the stroma and some of the cytology potentially. You can also have capsular alterations, which can mimic capsular invasion. And the hint that it's just capsular alterations due to an FNA are the changes listed above. Metaplasia, if you see infarction, fibrosis, nuclear atypia, some of that can just be caused procedural related changes. All right, next up, we've got amyloid goiter. So this is a mass enlargement due to amyloid deposition, usually with diffuse amyloid deposition throughout the gland, and it can be angiocentric or centering around vessels. Often compresses follicles, causing primary or secondary amyloidosis and leading to medullary or associated with medullary carcinoma. And amyloid goiter, or amyloid in general, as we all know, stains with Congo red, which makes me think of the Dr. Glockoflocken, or however you pronounce it, skit where he talks about pathologist's favorite IHC being Congo red, and then he refers to that person as a pathology bad boy. So I don't know if you've seen that video, but it's pretty funny. So if you're a pathology bad boy and you use Congo red, it may show apple green bifurengence, indicating positivity for amyloid. Next up, we've got adenomatoid nodule. which is an asymmetric nodular enlargement. Usually it's part of adenomatous hyperplasia with multiple nodules, but one nodule may be more dominant. The main differential diagnosis is a follicular adenoma. Since both are benign and there is some inter-observer variation, some people just say benign follicular nodule, or BFN. So a little table to distinguish between an adenomatoid nodule and a follicular adenoma. For adenomatoid nodule, think polyclonal growth, unencapsulated, may have variable, incomplete, and surrounding fibrosis, with multiple patterns of growth resembling background thyroid, with relatively abundant colloid. There's often multiple nodules, and it's usually a pushing border. Contrast that with follicular adenoma, where you're going to think about a monoclonal neoplasm. It's going to be encapsulated with well-defined, fibrous, and often with thick vessels. A uniform pattern of growth, typically, with distinct from the surrounding thyroid, and there's going to be less colloid, a single nodule, and compresses the nearby tissue. So very similar entities with subtle differences. Multiple things, you're more thinking adenomatoid nodule if it's unencapsulated. If it's encapsulated, monotonous, uniform, monoclonal, single nodule, you think maybe follicular adenoma. So that's it. Just a quick little thyroid video. I hope you enjoyed, and I hope you have a great rest of your week. And I appreciate, and Jay and I both appreciate your support, and hope you have a good day. Take care.